manipulation adjustments all throughout school, right? Is that toolbox, are those set of tools, the manipulations, all the manipulations you need, or do you go to, are there Con Ed courses specifically teaching you other manipulations?
Bobby?
Oh yeah, there's loads. That's what most chiros are honestly doing, is they are taking Con Ed in those varieties of mobilizations.
Okay.
Yeah, for sure.
All right. And then with respect to mobilizations, manipulations, my experience has always been through, the things I've learned through the PT world as well as through osteopaths. And so it seems like the osteopaths really prefer taking manipulations and doing them at roughly mid-range. The ones I've talked to said you don't necessarily need to completely wind something up and then, blow through at range, the high velocity, low amplitude. Is there a variation in thought processes with respect to when and where you manipulate in the world of chiropractic?
Do you do it? Just curious before I answer, do you do any mobilizations yourself? I mean, maybe
Cuboid,
like
A
HVLA?
lot of cuboid manips.
Cuboid. At this point, the big ones I do are cuboid, CT, thoracic, ribs.
No cervical.
Cervical, I might do something in the mid to low.
Okay.
Up high, I don't really need to, right? At least I haven't found that need, right?
Sure.
But, from an FR standpoint, what's really cool is that you can get right there on the capsule and just, put an input into that all day. Pales efforts with it. And then, of course, with some PRI, it usually will clear. But, if you've spent enough time trying to get that capsule to let go and it won't, then that's where maybe you just come in and just push it right through.
Mm-hmm.
Yeah, so...
well, I don't know. I mean, at least for spinal manipulation, most of the stuff, at least I'm familiar with, or whatever was taught to me, was more end range stuff. It doesn't always mean it's as high a velocity as you may need.
Yep.
I mean, I've learned getting a person set up correctly makes all the difference of like what you really have to do as far as adjusting or how hard you need to do anything. I probably do a lot more adjusting than John does, but it's still only as necessary, right? But right. I'm with you with these the osteopaths. Like I send people to osteopath. There's like one or two here in Iceland. That's it.
Yep.
And I send people to them, and the first time I was sending people to them, they're like, "Who sent you?" They're like, "A chiropractor." They're like, "A chiropractor sent you to me?" Because like in Iceland, it's like, dog eat dog over here. Everybody is the king. Nobody relinquishes a patient.
Right.
So yeah.
What is it? There's what? 30. Wait, what's the population of Iceland? Because I remember I was looking up time zones and all that for this, and I remember like the population up there isn't that great.
No, 320,000.
320,000, yeah.
And 210,000 is in the capital where I am.
Right, and so with respect to here in America, with all the cash PT consultants and mentors and gurus and whatever, they always want you to have that abundance mindset, and I'm like, I don't know if you can have that abundance mindset when you've got, when you're fighting over that small of a population. I don't know.
That's tough.
Yeah, I think if I was a physio, I would feel that more. There's just so few chiros, so it kind of, the people that are sick of, I guess, mainstream physio, mainline, the standard operating procedure.
Yep.
They want something else. We get a lot of those people. So that's kind of where, But we'll let the proverbial Bruce Buffer over here maybe get this.
Well, let's get started. This is a good. I love this conversation. I mean, we can just go wherever we want to go today. I'm like, are we recording this? This is good stuff. But yeah, just naturally, whatever happens. I'll just kind of be like, hey, we're starting today, blah, blah, blah. Who gives a shit? And then I'll be like, I'll let you kind of introduce yourself if that's all right. Because I don't know you. But yeah, so we'll just take a second to introduce. I'll say the podcast is starting. What do you want to go by?
Loc is fine.
Loc?
Yep.
Cool. Sweet. I'm pretending there's music going. And welcome to the Anatomy of Therapy podcast. I'm Dr. John Sobolski here with Bobby Riley. Today we have a very special guest out in California, the beautiful Southern California. Pasadena, I think. I actually don't know a ton about. That's why I'm kind of excited to talk to him today. I've actually been following you on Instagram for a really long time, kind of stalking you from the shadows. But I'm really glad today to have a conversation, hopefully learn some things. But I'm going to kind of let you kind of introduce yourself. Dr. Loc, welcome to the podcast. Who are you? Where you're from? What do you do?
Yeah, no, thank you for having me on. I am one of those statistics. I was born and raised and grew up here in the Pasadena area. The San Gabriel Valley is what it's more commonly referred to. Did everything straight through. I went from high school straight to undergrad at USC, where I received my degree in exercise science. That's how old I am. It's gone through 2 name changes, and I think now it's called kinesiology. But there was another name in there for a while. I forget what that was called, but my degree officially says exercise science. And then after that, I went straight into physical therapy school at USC as well. From there, I went straight into a very busy outpatient orthopedic clinic, where I was tasked with seeing everybody. Inside of 2 years into my professional career, I was running into burnout problems because I had seen 38 patients in a 10-hour day, and I was like, this is not going to cut it. So after that, I went into private practice for myself and have been so ever since. About 7 years ago now, I moved into the space that I'm currently at and expanded and brought on the whole thing with employees and systems and an employee handbook and all that stuff. And now I'm beginning to slowly venture away from that. But with respect to where I'm at, I'm in Pasadena, which is about 10, 15 minutes north of downtown LA. If you've never been to Southern California, specifically the LA area, LA really isn't like a city. It's just like 40 cities that are just sprawled out. And, technically speaking, it can take you an hour and a half to get from one end of LA County to the other, if not 2. Mm-hmm. So I'm in my own little pocket of the world called Pasadena.
Nice.
It's a nice area. I'll probably get a lot of shit for saying this, but within all the different parts of LA, Pasadena is probably the pocket of LA that has the quote unquote most normal people.
Nice. I noticed you also host a bunch of courses. I might be wrong with that, but what are some of the, because speaking of your clinic, you talked about systems and handbooks and stuff. What are your most recent courses you posted? I feel like every cool course I've ever been interested in has come through your clinic at some point. But yeah, I'm sure it would take another hour to list all of them, but like most recently, but yeah.
In February, right before the whole world shut down, we had actually hosted PRI's Cervical Revolution, and then we had also then hosted FR Spine. And so in years past, we had hosted some other FR courses. We've also hosted a bunch of Movement Links courses. Movement Links is the offshoot of Claire Frank. As you know, she's one of the DNS international instructors based here in the US.
Legend.
We've been actually, this upcoming August, we're supposed to host Myokin for PRI. But we'll see if that happens. We're probably going to host another FR course. But usually when the people from Toronto give me a call, they're like, "Hey, can you host?" They'll give me like 2-3 months out. I'm like, "Yeah, sure." So that's kind of how it works with them. With PRI, it's a little formal. It's like 10 months in the process, in the making, paperwork galore, things of that sort.
Sure.
In your introduction, you mentioned your kind of, let's say, time-consuming and difficult work immediately out of school with the outpatient orthopedic stuff, and you mentioned PRI, and I know Ron always brings up his VA medical, his prosthetic, all this stuff he did, dental school, all this stuff that he had to put himself through. I mean, would you still recommend that for these PTs coming out? Did you find some value out of that, despite the long hours and the burnout?
I believe so. I mean, I think what it comes down to is that, I've said this before, no matter who you meet in life, if you keep an open mind, you can always learn something from them. Like they're probably going to know, they're probably going to be more knowledgeable about something that you aren't. And so you just have to, keep your eyes and ears open for what it is that you might pick up. In that same regard, as much as I didn't care for that volume model, I have to be honest, I was exposed to so many things that really helped me out for the rest of my career. So, for example, I came out of school owing a ton of money. And so in my attempt to try to solve that problem, this clinic that I worked at had a satellite office based out of one of the big box gyms. And so I used to work 4 10s at the regular clinic. And then I would work my 5th day at this other facility. And so it was really cool growing that, right? It was out in the boonies or a little farther out. And so we had to make new connections with orthopedic surgeons and, cultivate new relationships. But then also at the main clinic, they did also offer Saturday hours, which was a lot less busy. We did it as a service to the patients. And so during those Saturdays, those were my opportunities to really get a chance to spend more time with the patients. And I would see, for myself, how much more I enjoyed that setting. And quite honestly, just how much better people got when you weren't, scrambling to think about, hey, I've got 15 minutes with this patient before I then, got to do my notes and then skedaddle on to the next patient.
So how long do you typically, just now, I've seen, like, you're on the top of my feed every time I turn on my Instagram, but like, how generally long do you spend with your patients now? Yeah. Ballpark.
Well, all my visits start at 1 hour. And so, that's a majority of my caseloads. They come in and I'm booked with them for the hour. But I do also, actually before we shut down due to the pandemic here, that second week of March, I actually had set a personal record. I had 9 2-hour visits that week. And so I do offer that. And it was kind of weird at first. I was like, I don't know if it's going to be a big deal, but, without giving away too many trade secrets, the crazy thing is that people really enjoy having the time to spend with someone they trust. And, after my own recent visit, I had a visit with a specialist doctor, and, it was 45 minutes of waiting in the lobby and, being scuttled into a room and then basically spending 4 minutes with the doc and then, being skedaddled out back into the reception area. And I was like, oh, okay. It made me kind of realize, yeah, this is really why my model works. And so to answer your question, 1 hour is what I offer as a baseline. I do have 2 hours, and I had one person, do a 4-hour session with me. So it's all out there.
So before we dive in clinically, do you just have without your giving up your trade secrets? Do you have a mixture of like cash and insurance contracts? And
so currently, I personally do not see any insurance patients, insurance based. My personal practice is 100% cash. The clinic that I own, we do not contract with any private insurances. However, we do still contract with Medicare, and that's for business reasons where, if the therapists aren't able to keep their schedules full with self-pay patients, they can always rely on that. And it's actually a tremendous value for those Medicare patients, because we block out an hour for them. And I know that there are PT clinics all over the area, including probably all over the country, that look at Medicare as like this golden cow where you can see 4 patients an hour. And even though you're supposed to use different billings, I know that they're billing for full visits, which is obviously something that we're not going to do. But so to answer your question, my personal practice, I do not see anything on the insurance side. Even with with the pro athletes have really great insurance through their organizations. Those athletes, we just tell them ahead of time, hey, you're just going to pay us up front. We'll give you this paperwork. Your agent or yourself or whoever is going to file it on your behalf, and those insurance companies, at least those plans that those athletes have, they reimburse pretty well to them. So the athletes love it.
Yeah, I worked with the NFL right out of school, only NFL players, and yeah, Cigna just covered anything you wanted to throw at them. So
right.
It was kind of nice.
Right.
I thought we would leave. I was scrolling through your Instagram and noticed one post that said, a bad hip will shit upstream and downstream.
Yes.
And I just thought I just like that as a good gateway into what you do, because I think us three speak a lot of the same language.
Yep.
And that particular topic, I thought, well, I could take that from different perspectives, right? You could take it from a FR perspective or from other course perspective, or just try not to look at it through one of those lenses. It could just be through your own, whatever amalgamation of knowledge that you have at this point. Yes. But I mean, I wanted to maybe lead off with that quote, and you could explain it a little bit. And I think that would help us start to dive down this rabbit hole a little bit.
No, of course. So, from an evolutionary standpoint, and even from like an engineering design standpoint, if you wanted to create the most degrees of freedom in an articulation, you probably would use a ball and socket, right? And so we have this beautiful ball and socket that we then rely upon to ambulate, right, to get around. And if you think of that pelvis, hip, lumbo-pelvic hip complex as this transition from one side to the other as we walk from side to side, the implications of that major, if you will, highway transition, right, not working well. And you think about the surface area, right? If you think about from a surface area standpoint, with how much acetabulum, right, sits on femoral head, and this labrum that's designed to do its best to provide stability without being a bone, and all the meat, all that musculature that is there with the responsibility of managing 2 hips about a pelvis, so that we can transfer energy from the ground into a limb for throwing a spear, right, for running, for any of those things that we want to do. And then in this modern world we live in, we basically take this super powerful, this super functional, this thing that is designed to have so many capacities, and we just put it in a cage, right? We just sit on it all day, and and hey, I got my 3,000 steps in, and it's like, well, that's nowhere near enough to stimulate what that hip wants to do. never get into a deep squat, right? I mean, all those different things that a hip really wants to do and be. And then we wonder why, if we're not training this ball and socket to move around and have all the different ranges and all the musculature about it to be strong and healthy and adept, do we wonder, is it any wonder why we have this back pain incidence, this phenomenon that just isn't going away? It's actually getting worse, right? So,
yeah, I was glad you touched on upstream, because I think when people think of the hip, and our demographic, our listeners are definitely more clinicians, right? So, but I think they tend to think more downstream with what when you think of the hip, right? Oh, it can affect the knee and it can affect gait and where the foot's placed. But upstream, I was hoping you would touch on that, because I think that the people miss that a little bit, right? We're too myopic where we look.
Right. Yeah, no, I mean, basically from an engineering standpoint, when you're standing, you've got these two pillars, right? And dynamically, you're trying to move this base, this pelvis, and the torso above it with everything that keeps you alive, right? Your wet cavity, I call it, your core, your IAP area, and your dry cavity, if you will, right? Your rib cage. Those things all have to have their own foundation, just like we think of the foot ground interface as our foundation for moving and standing. That pelvis, right, and what's supporting it, that's the foundation for everything up above, right? It's just another level of foundation.
Absolutely. I had a question. One of the aha moments for me while I was taking a course was a girl, I think is on one of their video courses actually, in Myokin, did a left glute med exercise. She pulled a leg back, the left leg back, and then had the patient breathe a couple times. And the patient said that they could feel their left back moving. And then she tested a left shoulder, and that left shoulder started to move. And I was like, what just happened right there? I need to know more. Anyways, and so that was probably 7 years ago now, but I do remember that moment kind of very clearly in my mind. With all the kind of 3-letter courses that you've hosted and that you've been a part of, was there a moment like that for you? It didn't have to be PRI, it didn't have to be DNS, but was there one of those moments for you where like, oh, does that make sense?
Oh yeah, absolutely. I think anybody who's taken a PRI course will tell you that every single PRI course has one of those moments. And I think one of the prereqs to become a PRI instructor is that you have to be able to tease out from the audience who is absolutely 100% this pattern as it applies to the course. So I'll tell you my first aha moment was, I took Myokin as my first course. And so I'm sitting there, and I'm always a front row guy. So I'm sitting there in the front row, and if there was a camera on my face that first morning lecture, I would love to see the recording of that, because James Anderson's sitting there talking about how this diaphragm has so much power over everything else, and not just from a stability standpoint, right, which is where DNS wants to go with it, but from the implications of walking, shoulder and hip mobility, all these different things. And there was definitely a facial expression of like, I don't know if I'm buying what this guy's selling. And then he pulls up this one gal from the audience, gets her on a table, does a couple of things, and gets her to go from a positive adduction drop test and a very positive right HGIR test to completely neutral in 3 breaths. And my only thought at that time in the front row was like, she's got to be a plant. She has to 100% be a plant. And so with every single PRI course, you know, it's been one of those experiences. But after that, you know, when you think that you've seen it all. When I took the vision course, the postural visual integration course, the things that Ron and Heidi were doing to the different subjects that they pulled out that weekend were just crazy. I mean, you know, there was one instance where Ron was having a guy feel something as he was talking, and as he kept continue to feel it, the guy, not knowing, eventually fell over, and Ron caught him. Like, he didn't know that he was going to fall, and so there was that.
Sure.
And then Bobby, I don't know if you remember, you know, at Advanced this past December, there was a little spiel where Ron kept on saying all weekend, but you know, we only have 4 days. We only have 4 days. And then when he goes off and talks about how you can tell this person's facial nerve is overactive because of this, this, and this, and I was like, oh, yeah, I get it, but I really don't. So there have been lots of those. But then also, I mean, those are probably the biggest, like, black and white, like, complete 180 type moments have most of them have been in the world of PRI.
Yeah, they definitely have that effect. Go ahead.
Yeah. Well, I think you're a lot like me in the sense of being very skeptical, and the skeptical listeners should be exactly that, skeptical. And if you take somebody like Dre, he'll do those presentations in front of the class where he says, come up here and lay on your back and let me check your straight leg raise.
Right.
And then he, you know, flicks them in the air and they check it again and the straight leg raise is better. Then he brings up another person, does the same thing, but instead of flicking their ear, he just walks across the room and punches the punching bag that's there in the gym, comes back, checks the straight leg raise, and it's high, it's better, right? And he's trying to say there's a lot of these party tricks out there, and they're a waste of time, and they're red herrings. And I was with you in that same boat in the sense of whatever I learn, it has to anecdotally, at least, or in my experience, has to come to fruition and prove itself over time. You know, that's why whenever I see somebody doing something like an HGIR test and I see them anchor the shoulder blade different post-treatment, I'm always a little pissed off, because I'm like, why? Who are you? Are you trying to trick yourself or just the audience? But either way, just I always want it to be authentic. But these courses, I think that we've all kind of at least learned a lot from, tend to check out over time, you know?
Right. No, actually, you know, I don't know when it happened for me. I think it might have been maybe during a movement links course. But, you know, for me, I gave up a long time ago, you know, after looking at like what I was doing the first part of my career. You know, that whole lying to yourself thing. And if you're lying to yourself, you're lying to your patient. And if you do that, then you're just a scumbag clinician.
What do you mean by lying to yourself in terms of like the party tricks don't work, or what? I'm sorry.
In terms of, you know, maybe the tricks don't work, or maybe you didn't get the outcome that you wanted, or maybe your questioning is more guiding, right? You have guiding type questions. You know, for me, one of my things that I say all the time in clinic is like, hey, I have no emotional attachment to this outcome, right? Like, don't tell me it feels better because you know, want it to feel better, or you want me to feel better. I'm like, hey, whether this works or not, right, tells me exactly where we need to go. So don't lie to me, just be honest. Right?
Sure.
So that's something that I've evolved into using as one of my normal, I guess, mini spiels, if you want.
So I just wanted to throw in, I like that, because one of the things I'll do is, if the patient is alone, I'll write my answer down on a piece of paper that they can't see, or I'll show it to the mom or the dad, whoever's there. I say, I want no part of influencing your answer. So I'm going to write what I think here, and we're going to see if these things match up. So when I say, which side do you not like your head rotated to?
Yep.
I'm going to write it down separate. You tell me your answer, and
yep.
you know what I mean? And and you get this authentic nature, and it's more objective. You are trying to separate yourself from that outcome. But yeah, go ahead, John.
No, I mean, yeah, we've talked about this many times before, but in terms of the tests, there are some of the, the glenohumeral internal rotation or the horizontal abduction, your basic Auber's test and straight leg raises that are necessary to do. And then in terms of a patient, let's just say strictly with like glenohumeral internal rotation. If I go through a treatment and at the end of the treatment, that internal rotation is more than it was at the beginning, I might be, let's just say I am an emotionally attached person. I might be very happy with that outcome. And I'm like, great, we accomplished what we wanted to do. But then I look at the patient's face and they're like, oh, why does that matter, man? I told you my neck hurts right there. You know what I mean? I understand like the whole treatment process kind of goes together, but this was kind of my growing up, learning the difference between these important you should do a straight leg raise test. Please don't hear clinicians we're telling you that straight leg raise test and internal rotation don't matter. You need to test them, of course, and mark your movements before and after, how much range of motion you got or didn't get. Those tests don't lie. But are there some tests or measures, I guess you could say, in terms of how your patients might notice they're better, like their toe touch? I think you had a telehealth recently posting where a woman was doing like a flexion pattern and a toe touch, and that it was awesome. And I, again, don't give away all your fun stuff, but are there tests you find that patients seem to care about a little bit more than my Auber's test, if that makes any sense?
Yep. And so the thing that I was taught a long time ago, I really forget what world this came from, but there's something that I just tell my patients. It's like, hey, I always want to know what your asterisk sign is. And so the asterisk sign is something that they know that every single time they do, it provokes their pain. And so that is a value to them, right? And so I will say, hey, look, like, we will use that in context, because really pain is a terrible outcome measure. But it is something of value because pain has emotional attachment to it. And so we will use that. And then with respect to them, I will try to give them something that is a little more objective in nature or clinically relevant to me. And I'm like, hey, I'm going to meet you in the middle. You have the thing that you go off of. And if I understand this correctly, and if I can think of the pathomechanics, the pathophysiology of, hey, why does in that lady's case, why is it in her case, she's a yoga instructor who couldn't forward fold past torso parallel. And so I wrote in that post, really not a good look for the yoga instructor if you're standing up in the front of class and telling people, hey, let's forward fold into toe touch, and she has to stop at the halfway mark because of pain. And so, the forward fold is a clue for me, and it's of value to her, but then I'm gonna reconcile it against some of the other things that are of value to me. And with respect to PRI, or even FRC, if someone comes to me with let's just say a neck issue, right? I'm absolutely going to teach them about CARS and how they can use that as a general everyday assessment, because they are clearing the neck in they're assessing the neck in all of its degrees of freedom. And then maybe I might then relate it to most likely a cervical test. I mean, instead of the passive cervical axial rotation that we do with the table test, I'll just have them rotate left and rotate right. and I'm going to ask them to, hey, feel your feels, right? What does it feel like at end range? Reconcile it against your cars, and we go there. You know, even though that person might need an orthotic intervention, or, you know, a left hamstring to take care of all that, you know, I'm not going to go there on day one with them, right? Because they're going to think of me as like, oh, this guy's crazy, right? And then, you know, my ability to help guide them along is now severely diminished.
Yeah, I think I saw you you did a live Instagram with a patient not too long ago.
Yeah,
Is that right?
I threw that up just to do it. Yes.
Yeah, and one of the things I noticed about you was you were doing that. You were involving your patient, and you were, you know, it wasn't just about you, in other words. And when I mean just about you could still be genuinely trying to solve the problem, but it didn't seem like, what do I need to get out of this? What do I need to know? And what interventions do I have to implement? You were very much involving the patient and what they feel. How do you feel now? What's different about when we started? And I think a lot of clinicians miss this part. I think this post-treatment, this, what are you aware of? What do you feel now? Giving them this, making them speak of what they're aware of to notice any change. And we could be doing all the same things, you and I, patient for patient, but I'll just stop after I do my thing and let them go. And you do your, this interaction that I kind of noticed that you do. And one of us is going to have the people return and one is not, even though the same, intervention could have been delivered.
Right. And so, I didn't really realize I was doing this until I sat down with, when I sat down with James Anderson for lunch last November, when I took respiration in Arizona. One of the things he told me was like, hey, really what Ron's ultimately trying to do is he's trying to figure out what the brain is taking in and processing. And so the less you treat the person in front of you with their orthopedic issues as like meat bags, right? Like, oh, this shoulder doesn't move because of this, or, this hip doesn't have the entire range. Ultimately everything's governed by the brain, and the brain has so many different subsystems inside of it that ultimately you have to give that person the emotional foundation of safety, of security, and knowing that you're on their team and that they have someone to help them through this. There's nothing better in the world when you're the learnee, right? The teachee, as having a great mentor, right? And so really, instead of this patient-clinician relationship, I think if we go mentor-mentee, that relationship, right, then we can help guide them along. I think that's the relationship format that I try to establish with the people I'm working with.
That's fair. Okay, so that's awesome, man. Sometimes when I see people who say that they do DNS and PRI and FRC stuff, they tend to, whichever specific camp that might be, they tend to force people into that particular model. If I've ever talked to the Jameses or the Cantrells or the Claires or the Mikes, that's not necessarily the case. They talk a little bit more like you talk, in terms of meeting the patient on that kind of same level, which I love hearing, because I don't know, I just feel like a lot of people have a certain amount of skills, or they think they do, and they try to get a patient and then shove them into that kind of level, and then they kind of wonder why there's a head butting going on. They're like, why don't you care that you now have your Ober's test is now negative? Why doesn't that bother you? Was there, you have a super even keel. Was this kind of the turning point from your burnout to opening your own practice, or where did this perspective to kind of meet the patient where they are? I mean, I think I wish more clinicians would do it. Do you think you've just developed that over time? How long have you been practicing? I forgot to, 45 years or something?
18 years.
Oh, okay, cool. Yeah. Where through your practice, I mean, I can see myself Bobby and I have been out about 10 years. So, but the first 5 years, the first 3 years, and just looking back and be like, dear God, where did you kind of, develop that outlook?
So as a teenager, I used to work on cars a lot. And so whether you're working, and then from there, I transitioned into doing a little bit of construction, handyman work type of things, right? And what you come to realize in both of those scenarios is that nothing sucks more than not having the right tool for the job, right? And so if you think about how complicated a car is, let's just say, just even a transmission, right? From a mechanical engineering standpoint, an automotive transmission is one of the great accomplishments of humanity, right? And so if you think about how complex that is, and then you think that the human body is like a million times more complex than that, there is no possible way that a single tool, a single approach is going to be enough for that person in front of you. I mean, I can't tell you how many times I've tried taking care of someone when I was younger, and this person might have been really an endocrinology patient, presenting in a physical therapy clinic or something else, right? And so really, when that person comes into my world and is appropriate for PT, movement, whatever you want to call it, now the thing is like, hey, I need a screwdriver here. I need a ratchet here. I need a hammer here, right? So I think some of my upbringing was some of the things that I did as hobbies, and realizing that, like, there's no such thing as the Swiss Army knife, right? That's really functional. Even a Swiss Army knife, right? All the different little gadgets that come on a Swiss Army knife, they suck at everything they do, but you have it, right?
True. That's a good point.
So that's really where I think I've come to appreciate that. But also I think part of it has come in, I'll be honest, when I was going through my FR courses, I loved the FR courses, and for like a good year and a half, I did FR release on everybody to my hands, demise. But, it was more, part of that was the exercise, right? The exercise of knowing how to palpate to that level, right? Knowing how to find things to that level, and understanding and appreciating that if I'm trying to open up an angle, per se, of a joint, you're going to spend 20, 30, 45 minutes there. Open pails, inputs, pails, right? And then, when I first got exposed to DNS, hey, everybody's a DNS patient for a while until you until basically you eat shit and hit a brick wall with how you're progressing, right?
Sure.
You're either not good enough at it, or you're trying to pound a nail with a saw, and that's just not going to work.
Yeah. No, I mean, all those courses, I see a lot of people say that they do DNS, and then you watch them and they've just learned, the 3.5 month position or bear. And I know there are a lot of, it can go so deep, or with the FR stuff. I've seen just knowing different types of manual therapy through chiropractic, it takes a while to get good at it. Just because you go to one course does not mean you understand how the diaphragm works and how to apply that to a large group of people. But so I do appreciate, obviously, getting in the reps and being honest enough to be like, I ate shit, because I definitely have plenty of times when I'm like, let's see if we can get this IAP. You just don't understand what I'm talking about anymore. You know,
right.
It's not just in the patient's value system.
Right. I mean, even within the world of, I can tell you this, I'm not going to name names, but even within the world of just those three modalities, those three approaches, right? Like, you know, on the FRC Facebook group, which is their most, that's probably their busiest place for interaction amongst everyone. I mean, you have people, you know, who have just taken FRC, and the types of questions that they're asking, you're like, oh yeah, you have a long ways to go, right?
Yeah.
But even within the world of, say, DNS, you know, I know, because obviously I have a few friends who are instructors and assistant instructors. You know, they've expressed to me that, like, hey, you know, the criteria by which you can go and, you know, go to Prague and take D course, they've expressed that probably should be elevated. You know, just because you've qualified on paper doesn't necessarily mean you should go to D course and, you know, and test for the DNSP certification. Mm-hmm. And the same thing with PRI is that, you know, I'll simply say this, you know, I was speaking to one of the PRI faculty, and they just said, hey, you know, understand that not all PRCs are the same, right? You're going to have some that, you know, that have it and that was it for them, and you have others that, you know, continue to that understand and respect that it's a stepping stone, right? And they continue to move on with that. So yeah, so I mean, you know, just because you take it, right, doesn't mean that you're good at it, right? I mean, I was actually where was I at? Well, I'm not going to say, but I was at a course a while back where you know, one of the hosts you know, got their cert, right, but wasn't there the whole weekend, right? So it's one of those things where, you know, you can just pay for the course and not attend, right? There are some groups that aren't as strict about it, and then there are others who, you know, but then also understand that at least for me, I hate to say this, but I am that guy. Like, if you ever give me your cell phone number, holy crap, am I gonna text the crap out of you with respect to questions, right? So, like, you know, I think I've asked Mike Cantrell my allotment of questions. Now I'm asking now I'm asking Casey Aiken right now. You know, so Claire Frank has gotten a million questions from me. Michael Chivers has gotten a million questions from me. So, you know, it's one of those where, you know, it's always good to hear it from other perspectives, as I'm still trying to interpret it all for myself.
That's good. It's funny going back to these courses, and John and I have kind of self-coined, at least we believe so, the term like new course syndrome. Yeah. And this idea that you take a new course and then you just start implementing it right away. But and of course you're nowhere near where you need to be using that. But it's kind of a paradox, right? We all have to go through the stage of ignorance. We think we know what we're doing until we realize we don't.
Right.
And it sounds like you parsed that out, whether you meant to or not, quite well, where you went through your continuing education. Maybe you can correct me, but like in streaks where you studied something and then you moved on, and you studied something and then you moved on, where a lot of people are just, you know, courseurs, you know what I mean? They just take everything, and that must axiomatically give them all the power of those courses. And they presume that they understand everything. And I even think maybe 5-6 years ago or something, John said something to me about, hey, I asked him about, are you going to take this new course? And he was like, no, I'm still studying this stuff. When I got this down, I'll move on. And that was just, I loved hearing that. And it was a little bit of a wake up for myself. And since you are, you know, we're chiropractors that are probably treat a lot more like PTs and physios, but you're a physical therapy doctorate. And would you, you know, is there any advice or, you know, based on the path you took to get through this, because again, no matter what you do, you're going to be, going up battling, you're Sisyphus pushing the rock up the hill for most of your career, in my personal opinion.
Right. Well, I mean, I think you have to understand that I mean, I'll try to tie this all in, but understand that like you can only teach so much in a 2-day weekend, 3-day weekend, right?
4-day weekend.
4-day weekend, right? And on the flip side, you can only take in so much of that information. And depending on where you're at in your life, right? If you've had to travel to a course and, you have business matters to think about at home, you have family, personal matters, kid matters to think about at home, right? It's a little tough. And when you think about how much you got in school, and here they were teaching the stuff to you for 7, 8, 9 hours a day over the course of semesters, right? And now you're supposed to say, okay, well, it took me 3 years to learn how to properly, manual muscle test and apply activities, to then be like, well, I took a 2-day course and now I'm well versed in, myocin. It's like, well, no, right? Like it doesn't work like that. And so the reality is that, depending on the subject matter and depending on your background, what you're ready to see and hear it differs from where you're at in your life. Like, the first time I took respiration to the second time I took respiration, those were 2 completely different experiences, right? The first time I took FR spine to the third time I've taken FR spine, completely different experiences. And so, to think that someone's life work that they put into a 2, 3, 4-day weekend, that you're going to get it all after having taken it once, that's silly, right? I mean, you're getting their tip of the iceberg. You're not there's so much of that context that they've cut out, right, for the purposes of being able to express it to the audience for the entire weekend, that ultimately you just have to go back and keep trying to find the details.
I mean, I think you can get that sense just from when you were in school. I don't know if you guys did or when you did cadaveric studies or cadaver studies.
Yep.
Like I did it first trimester in chiropractic school. And I remember thinking, why in the world did I do this in T1 when I could have done it after the 3rd year? And I mean, you can just make me take the test, pass the origin insertions, know all the bony prominences. That's fine. But why do the cadaver studies at the same time? Do them right before you graduate or after a year of, working in a clinic with somebody. And that, you don't even have to be out working like you are for 18 years. You can see that just in school, the difference between if you had that scenario happen at the beginning of your studies or the end, or us going to do a cadaver study right now, the 3 of us, right. All 3 massively different experiences.
Right. And then this also speaks, I guess, to a certain extent with respect to maybe how some weekends are formatted. I'm currently working on a seminar for myself, and one of the things that I've noticed over the years was, you'd go to a weekend seminar, you'd learn 60 different techniques, and you'd come back on Monday and you would suck at all 60. Maybe you were somewhat kind of sort of competent in 2 of them, right? And so so there's that as part of one of the issues, right, with trying to learn these things on the weekend.
I noticed one of the bigger shifts for me was I used to practice up in Austin, and there's a great PRC up there who taught me quite a bit. He's kind of like, you gave me your number and now I'm texting you questions on Friday night. But anyways, he also was kind enough to let me borrow some of his old course books. And so like I think he was, at this point, he's been a PRC for, I don't know, 15, feels like forever. He was like, I was like the 4th class. Anyways, it was awesome. A little jealous. He's like, it's changed so much. Of course it has. But some of those old PRI manuals are very, very different than the ones that are now. I'm sure. And you've had a relationship with some of these guys. So you get to talk to them, quote unquote, off the books. And I do appreciate how their weekends are refined. And I think it's the same sort of relationship that I would like to have with a patient, where I'm not going to talk a lot of jargon. You know what I mean? I'm not going to talk about their big toe and their pec minor right now. We're going to stay localized. But some of those old courses, they have all sorts of fun little tricks. And maybe it's just the way that I learn when you find those little things. And I'm like, okay, I got to figure out how Ron got from the big toe to the pec minor, because I know that there's a way. There has to be a way. I'm the skeptic. I'm not as immediately skeptical. I'm like, okay, it works. Why? Let's parse this out. Yeah.
You're the magician who wants to figure out the other magician's trick.
Absolutely. I'm happy to put in the work to do that, but it just kind of pops open this little light bulb, and I'm like, I didn't know that was possible. And that's one of the things I love about some of these CEUs, where you think you're kind of trapped in a little bit of, you're like, I can do this, I can do that, I can foam roll a guy, I can Theragun their leg or whatever, and my box is this big, and that's that. If I can't fix them, it's probably the patient's fault for not doing their exercises, right? Or whatever it might be. But when you leave a course, because you've done so many, and it seems like you've got a good mindset in terms of picking up things and, taking time to work through them, or, you've learned through the years. I would be fascinated to see what your notes look like, first of all. And obviously it's different from time to time, but what is your kind of mindset kind of going into some of these courses? If I may.
No, of course. So going into all the courses, I'm always reconciling. So when I go into a course, I hear something and I try to reconcile it with what my current body of knowledge is. And I sit there and I try to think about, why is the instructor explaining it this way? Where might they be coming from? And then I try to see it as, how does it fit within their entire framework, right? And so that's really how I go about it. And then it comes down to, from an application standpoint, when might this be appropriate? Do I know anything else from other modalities that might complement this? Are there other things that might be contraindicated? I really don't think so much of the contraindication portion. Every so often, it'll just kind of flow into my head. But for example, I posted about this, and the PRI subclavius manual technique, absolutely, in my opinion and from what I've seen, it's the ability to separate that rib cage from that clavicle after having done like an FR release technique to subclavius. It's completely night and day, right? And so, it's one of those things where I don't even consider them two separate things. Like, if someone has the need for subclavius release, they are getting that, and they are getting the PRI version. If I'm treating someone through a PRI lens, and the respiration testing leads us to say, hey, this person needs their superior T4. Yeah, great, they're superior T4, but guess what? They're getting subclavius manual release, and they're getting the subclavius manual technique. If I get to someone who is from an FRC standpoint, like, hey, I actually did this with Miguel Arangacello, the PRT. He came out for FR spine, and on his left side, stuck clavicle, right? Release subclavius, and I just flipped the PRI manual release technique for subclavius, or manual technique for subclavius around, and did it on him. right? And all was good. So
that's awesome.
That's good. I wanted to be cognizant of your time, but I know that you texted me that you've been learning some new things, being in isolation and treating patients remotely now.
yeah.
And we've been giving a lot of courses some credit, and they can Venmo us later. But I wanted just to hear from you and your own insights as far as going through this COVID. John and I did a couple episodes about it, and kind of helping patients in some way that we hopefully, or clients or clinicians, that the best we could, give some advice. But what is that stuff? I know you wanted to say something about some stuff you've learned or that you've had to adapt during these times.
Yeah. So from a business standpoint, the first thing I did was I actually, went and forced myself. I'm improving on my tech savviness, but I forced the issue with respect to going out, figuring out how to do the whole Linktree thing with Acuity, because that first, I don't know, the first week and a half, I mean, the amount of thumbware, of texting people back who wanted a consultation, and then going through the process of booking it on my calendar and integrating it, so on and so forth. It was a lot of front end time before the actual appointment. So I figured out very quickly that, like, hey, if I create an Acuity scheduling account, link it up to a way for them to pay me, and link it up to my Linktree, anyone who messages me on Instagram, or even before they message me on Instagram, they'll see it in my bio. But then also Acuity has its own my own URL. And so if I get people inquiring via email or Facebook or whatever other ways it might be, just like, look, here's my schedule, right? And then on Acuity, it lets you fill in, it lets you have the patient fill in some of the history, some of the questionnaires that you want them to do, so that you don't spend that time. But then with respect to the actual sessions, what's really been great is that this quarantine has forced me to be more competent at queuing, because queuing is everything in this setting, but also then figuring out, what tests can I utilize that allow me to use my eyes and brain a little bit more, as opposed to my hands, right? Because I can't feel anything anymore. So I have to become better at using my eyes to see what I see, and then using my ears to hear what they're telling me. And so that's part of the mini evolution during these last 4 weeks.
Well, the Adam Meekins of the world would say it's probably arbitrary whether you're with somebody or not. They just need to train, right? So, and not saying we still like him, but I'm just wondering, do you see a negative? I mean, in a world where everything would be remote or telehealth, are we still missing stuff?
Oh, absolutely. I mean the this is above my pay grade, but with respect to someone's presence, their aura, there are certain things that you can pick up just in the presence of someone, if you're attentive enough. But then, of course, the power of really skilled hands, of a really skilled manual therapist putting their hands on you, that is still one of the most fascinating things and powerful things that I love to experience. When I go to seminars, in addition to being front row guy, I'm also volunteer person to get up there and be the dummy, because I really want to see, like, hey, like, what are this person's hands really like? So, and when you come across people who are really, really good at what they do, not only is it inspiring from the ability to affect someone, right? But it also inspires me to up my manual game, up my game in any and every which way.
There are, so back to what Bobby was saying, there are some people out there who frown on manual therapy a lot. Is it possible? Is it tenable to be able to do manual therapy effectively and also empower the patient? Are these two worlds, can they come together? Because there are some people, like I said, I do manual therapy. I spend an hour with my patients.
Yep.
What is your take on how you can, or can you? I don't know. Can manual therapy and empowering a patient, can those two things live together?
Absolutely. Absolutely. So with respect to manual therapy, I would like to think that with respect to manual therapy, I would say that it's one of those things where you use it for the tool that it really is, right? Which is to help the body guide along. But really, the body does a great job of taking care of itself once the rest of us get out of the way, right? So manual therapy has its time and place, but by no means am I ever going to make manual therapy anything that has an addictive or dependent quality of it, right? Here it is, here's the tool. Really, right, your body adapts to stress, right? And if the intent is to make someone stronger, more mobile, whatever you want to use, it's not going to be via my hands, right? The example I use in clinic is that think of a gymnast. I think a gymnast is probably the best example I can get people to think of in their minds. But at no point, I would say, would anyone ever say, like, do you think the gymnast got massaged or manual therapied to those capacities, to that ability? No, right? That is 99.9% training, right? So I really try to use that example. But, the power of skilled manual therapy has its place. And, unfortunately, it appears that all three of us here are in the manual therapy is powerful camp. But we're dealing with the fact that manual therapy across the board has probably been diluted with respect to its reputation because of people who have not used it as appropriately, and or the fact that there just aren't a lot of studies on it, right? Because there are no pharmaceutical companies backing up manual therapy studies that, right, want it to be proven as what it is. Manual therapy doesn't fit in the system.
Yeah, I think there's still an antiquated way that people claim what it does that causes problems.
Yes.
It's the same thing with the chiropractic field as well. This antiquated way of saying this is what it does because I was told this by somebody at some point in history. And often I think if things last for long periods of time, right, they usually have some value. What we discover is not that maybe manual therapy doesn't work, but rather the reason why it's working we had wrong. So maybe Cyriax transverse friction doesn't actually break up fibers and realign it, but it could desensitize the tissue for pain. It could cause the Golgi tendon organ to release something. You know what I mean? It just often comes from a different reason than we thought. So to throw things out just because an article says, yeah, you can't deform the IT band through pressure less than thousands of newtons doesn't mean that there's not some value in there intrinsically.
Right. Have either of you taken FR?
I have, yeah.
Okay. With Chivers?
No, with, yeah.
Serratiotis?
The Greek.
Yeah. Okay.
Yeah.
Yeah. I mean, I at this current time, I mean, I really dig their explanations for why they do what they do within the world of manual therapy, at least as it relates to, FR related inputs. And of course, I've had a few conversations with Michael with respect to how he and Dre, because they're trained chiropractors, how they utilize manipulation within their framework.
Yeah. That's interesting. And one thing about these guys like Shivers or Dre, sometimes I've got the question of how do you take the disconnect between something like PRI, who acknowledges that asymmetry is a really big deal, and somebody who does FRC, for example, where they are trying to get access to this joint again, maybe a shoulder joint, the humeral joint needs to act like a joint, but the PRI person saying, but it's in the wrong position anyway, so why would you do this? And I think the difference is I don't ever believe that people like Dre only treat through the lens that which they teach. Do you know what I mean?
No,
They have a much greater foundation, but they have to teach. Do you know what I mean? I think like you, I like where you have these, this way of reaching out into different disciplines and applying the tool, as you said earlier in the conversation, as needed. And I think these top guys do as well. And sometimes I wish the other clinicians that only go down one camp and fail to see that other ones offer value are missing that edge. You know what I mean?
Well, with respect to, I mean, you have to understand that in anybody else's position, right? Like anybody who teaches a seminar, right? You are now in the seminar business, right? And I don't know if this is an intentional thought, but every weekend or every dollar that the attendee spends at another seminar is a weekend or a dollar that they're not spending with you. I mean, I hate to be so cynical about it, but that might be part of it. I don't know.
Mm-hmm.
But, which I kind of get, right? If you're in that business, right? But in the end, I mean, for us, in my clinic, when people call us and they're like, hey, we want to go to a clinic that takes my insurance, we tell them, fine, there are 40 other clinics here in town that take your insurance. We'll even guide you to the best ones, right? Because ultimately they came to us as a provider to help them. And if the constraints they want to place don't allow us to help them because they really do want to use their insurance, we're going to lead them to the best ones. And it just makes it easier. We're doing the right thing there, but also, if it doesn't work, then it just makes it easier for them to transition to us. Right. And so I think that's really how it should be, but I don't know if everyone sees it that way. Right.
I mean, yeah, I like that, kind of taking it back to patients, just because that's what we do is see patients. But even from the seminar business, you said that the 2-day, the 3-day, or if you guys are lucky enough to go to a 4-day one, which sounds fantastic. You still have to refine, which is like those old PRI books to the new PRI books. You're only going to get so much across. And I think doctors need to be aware of that too. When a patient comes in the clinic, I want to tell you all about all the things right now. Right. However, like this first kind of stepping stone that we need probably needs to be a little more specific. But the second part, I wanted to kind of also ask you one other question about your clinic, because it seems like you see a lot of knees and extremities and stuff like that, or at least that's kind of the stuff we see posted. But like we've talked to other doctors about like finding your kind of niche, like say PRI or FRC, those guys at the DNSs of the world, they've found something. They've found people that are going to come to their courses. And they're happy with that. And that's great. Was it from your orthopedics background, or do you still see a lot of knees, or where have you I know you see a lot of kind of athletes as well. Do you see regular humans or?
So really, I actually am trying to, it's one of those things where I don't want to exclude anybody. but rather, I'm at this point, I'm just really more interested in interesting, right? I like the interesting presentations, because the interesting presentations are really what I think will help clue me in as to how maybe where I might need to go with what I know and what I don't know. So for example, I've been working with this one patient of mine for a little bit, and based on what we've gone through, I just actually on Monday I reached out to a colleague of mine who's an ENT, and I'm actually going to go in when all this clears up. I'm actually going to go in and pay for lunch for 2 hours where he and I just talk shop, because I'm like, hey, what does an ENT look at from their perspective? Because obviously how an ENT looks at that part of the body, we do have theoretically conservative musculoskeletal ways of affecting these things, as well as obviously we all know through the ANS how we can affect these things. And so, that desire to set up this appointment with this ENT came from a case who, this person has seen a lot of people and hasn't had complete resolution of their symptoms. And then, I've been working with this person for quite some time. And even through all this time, at our last conversation, it was revealed more in their history than I had ever known. And so it's one of those things where, just gosh, like thinking about a person's history, like the person's history is such a gold mine of information. But there's so many things that everyone wants to discount, right? Because they're now just focused on the current presentation, right? It's one of those things, as soon as I think I've got it all set up where my questioning and the way I set it up really gets me as much of a history as I want out of the person, then here I am, visit for it's like, oh yeah, by the way, this happened. And I'm like, oh geez, I did a terrible job of asking, right? Extracting that information. Yeah, so to answer your question, to be completely honest, and I probably will get in a lot of trouble for saying this. This probably isn't a good look, but like, I actually try to refer, more of my classic orthopedic cases to the others in my clinic, because those are kind of boring for me, right? Only if there's some other consideration like within the process that I need to come in for. I'm totally cool with that, right? But at this point, I probably saw, in my first 2 years out, I probably saw at least 300 ACL reconstructions, just because, that group that I was with was pretty tied in with a large orthopedic group. And then over the years, I've seen, so many of those types of cases. So for me now, it's just, to bring up that point, John, I actually don't post a lot about spine stuff, just because, when you're working with someone who's a spine case, right, there are so many things going on in the flow of the moment that I'm like, hey, I'm going to pull up my phone and do this, right? If you notice, all of my posts are just like, hey, can I post this? This is kind of cool and interesting. I don't really plan a lot of like, hey, if you have knee pain, do this generic bunch of exercises, right? That kind of stuff drives me batshit crazy, but we'll let other people do what they want to do. Spine, whole body type complexes. I have a few docs in the area of all different types who are just like, hey, I don't know what this is. Go see Loc. So I have it just has to be interesting, right? I love putting on the detective hat.
Probably those 2 hour patients. Sorry, go ahead, Bobby.
No, I was just wondering if you screen them through their new patient form that you get before you see them, or do you actually see them first before you would send them over to your other PTs?
No, I'll see them for the first visit, right? Because okay. I want to get a good gauge and pulse as to where they're at. Yeah. So for example, this is something that I'm going to include in one of my seminars. But what was interesting was like last year, I had two ACL reconstructions from two different surgeons, but one was a younger female, and the other was an adult in his 30s. And the younger female came in, and on day one, the parents were like, "Hey, we're going to book you out 3 times a week for the next 6 months." And I'm like, "That's a lot of money." Right. And I said, "No, I said, hey, normally my ACLs now, I usually see them twice a week for the first 2 weeks, once a week after that. And then, by month 3, you're coming in once every 2 weeks, and then once every month, as long as you do your stuff." And the 30-year-old who I saw, he was absolutely on that. And he started 6 weeks after the gal did. And by the time she was month 5 into her program, he had blown by her with respect to where she was at, and that was just a compliance thing, right? I wanted to pass her on to one of the other therapists, right, because I already knew that compliance and all that stuff was going to be an issue. It took me like the first 2 weeks to figure out, oh yeah, the reason why her parents are, doing 3 times a week is because she's not doing any of this stuff at home, right? And that gets kind of old. That's not really clinically satisfying, right? To have to babysit someone through their things, right? So, so in a roundabout way, all these different things come into consideration as to who I work with and why. And so there you go.
Cool. I think maybe we'll probably wrap this up, but I'm now kind of interested in maybe our last little point would be you've teased out that you're working on a seminar.
Yes.
Tease us a bit more. What is this? Is it more technique? Is it more building a practice? Are you talking about managing tough cases? Where do you want it to look like?
Yeah. So actually the seminar that I'm working on is going to be about improving the outcomes of people who've gone through orthopedic surgery. Because it's one of those things where I recognized it, 8-10 years ago, but never really thought about putting it together as a course. And, through these different things that we've done, these study groups that I've had, people coming in and observing, that I'm like, oh, I should probably turn this into a seminar. But basically, in a real simple description of it is, I'm effectively trying to up the game, raise the level of what someone who has undergone orthopedic surgery across the board, your average person who's undergone orthopedic surgery, what their outcomes look like, but also what the care they receive looks like.
Got it. So like, go ahead.
I'm just gonna say, I can see a massive demographic, which is there's a lot of PTs that do this post-surgical work, right? And that's kind of who you'd be looking to reach, right?
Yes.
Yeah.
What do you see, just really quickly, and then we'll probably wrap this up. I know you got young John back there running around, and you probably have to do his math homework or whatever with him. But what do you see as kind of the you saw this need? What was kind of the biggest fault? I don't want you to throw too big stones, but what is one of the big things they're missing that this course, whatever it is going to kind of cure?
Yeah. So there are when you're taking someone through the course of coming back from a surgery, in my mind, the way I frame it is that you have small check boxes and you have big check boxes, right? And I think that the small check boxes are sometimes thought of as big check boxes, and the big check boxes are sometimes thought of as the smaller ones. And when all is said and done, the outcomes are like, hey, here I am, or here this person is 7 years later after having hip replacement, or 12 years after having subacromial decompression. That shoulder still isn't right, that hip still isn't right. And I think the patient and the surgeon's expectation before going under is that, hey, when all is said and done, you should have a shoulder that resembles normal, right? Otherwise, why go through it, right? Why take that, whatever that statistical chances of going under and not coming back out of it, right?
Sure.
So, a lot of my cases are, hey, I had knee surgery 10 years ago and my knee's still not right. I had, spine surgery and it's still not right. The one that breaks my heart the most, though, are the people who've had, those spine surgeries, right? And the outcomes aren't what they expected. They're still suffering. And you get them to do a few things that all of us here would consider to be like fundamental basics, right? And those interventions did way more than the 8-hour surgery did.
I want to go to that.
Absolutely.
Course. That sounds awesome,
yeah.
Man. Bobby, any last questions before we?
I just want Loc to give us. How does anybody listening know where to find you or what's going on in your world?
Yeah. So I think my biggest funnel right now is my Instagram, Dr Locrao, at Dr Locrao, Locrao. I'm actually going to build out, or have it built out, just a landing page for drlocrao.com, just so that we can start building up an email list and I can put up a little bit of content. But that is the personal brand moving forward. It's just DRLOCRAO, whether it's Instagram or the website or anything else.
Very cool, man. I really appreciate your time today. We'll have to do this another time, maybe get into some deep stuff later, go down some rabbit holes. I feel like you go down some rabbit holes, man. And, but I really appreciate you coming on today during this madness in the world. But
no, thank you so much for having me. This is so nice to be able to talk shop with clinicians, and obviously with what you guys have done, a couple of clinicians I really respect. So really cool, really fun.
Awesome, man. Well, thank you so much. Thank you all for listening. We'll see you next time.
Stay safe. Take care.
Bye.
Thanks, Doc.
Bye.